അതും ഒരു ബ്ലാക്ക് കേട്ടോ, ബ്ലാക്ക് ആൻഡ് വൈറ്റ്.
Dr. Venkatagiri is also here. Venkatagiri, sir. Yeah. Kindly say 2-3 words of wisdom, sir, before we start the class. Unmute, sir. Unmute yourself. Giri, sir, unmute.
But probably he's not the host, sir. He'll not be able to.
I have already made him a co-host, actually.
Okay, okay. Now it's all right.
Yeah, sir. No audible, sir.
Yeah, now audible, yeah. Thank you, Secretary Dr. Bajwa. In this current year, I think is the first class I'm attending. Happy that a good topic of thyroid mass is being presented by the PGs of, I think PG of Karad with the faculty.
Krishna Institute, sir.
Yeah, Karad Krishna Institute, yeah, Karad, that is.
Yeah.
I remember that I have been there during my term as secretary and interacted with them. And it is good that we are having the PG oriented class more than theory to practical exam oriented, and it will be useful for everyone who attends the class. And maybe at the end we can ask others also to ask questions and know that what they have in that. All the best. Let us go for that. Now, Bajwa? Yeah.
Thank you, sir. Thank you very much, sir. I welcome everyone on the board. Now get prepared for a thyroid. This is another complicated case, and I am wishing all the best to Vikrant, because he's going to face some volleys of questions during the class also. Don't worry. This is a preparation for your final examination also. You have got 2 good professors with you. They will be assisting you also during your preparation and answering of the questions. To begin with, I request Dr. Monica to host this program and introduce the moderators also and presenter also. Dr. Monica, over to you, please.
Thank you, sir. Good evening and welcome you all to ISA PG online classes. To begin with, we'll start our session with Saraswati Vandana.
Monica, sound was not audible anyway, but Ma Saraswati Darshans are there. So you go ahead from here.
Okay, so our speaker for today is Dr. Vikrant. Dr. Vikrant is third-year anesthesiology resident in Krishna Vishwa Vidyapeeth, Karad, and he'll be presenting the case on large thyroid mass and aesthetic implications. Our moderator for the sessions are Dr. Naseema Kanase. Ma'am is professor and PG guide in Department of Anesthesiology at Krishna Institute of Medical Sciences, Karad. She is professor and PG guide and past secretary of ISA Karad City Branch. She is presently president of ISA Karad City Branch and GC member to MSCISA. She is faculty at state conferences with many publications. Welcome, ma'am.
Thank you very much.
Dr. Shraddha Nayak. She is professor and head of neuroanesthesiology, Krishna Institute of Medical Sciences, Karad, Maharashtra. She is secretary of ISA Karad City Branch and recipient of ISA Young Talent in Anesthesiology Award 2022. Her areas of interest include difficult airway obstructive anesthesia, basic life support, neuroanesthesia, And she has been organizing secretary of ISA National CME 2022 and PGCon 2022. And she's a faculty at many state and national level academic events. Welcome, Dr. Shraddha.
Thank you so much, Monica.
Now, I would request Dr. Vikrant to please start with the case. Before that, I'll just let my audience know that all will be muted during the session. And towards the end, we'll unmute you. In the meantime, if you have any queries, you can please type it in the chat box and the queries will be answered later on. Thank you so much. Over to you, Dr. Vikrant.
Hello, good evening, all my teachers. I will just try to present a thyroid case in front of you all.
Sorry, Vikrant, I muted everyone. Now you can unmute yourself. Huh?
Yes, ma'am. Yes. Good evening to one and all, everyone, my teachers. I will just try to give my presentations. Shall I start?
Yeah, please go ahead, please.
So, myself, Dr. Vikrant Vinayak Nishandar. I am third year PG resident. Today, I will be discussing about a case discussion on diffuse neck swelling. My patient is 45-year female, resident of Karad, Maharashtra, belonging to lower middle socioeconomic strata, presented with chief complaints of neck swelling since 3 years, progressively increasing in size since 1 month. My patient was apparently asymptomatic 3 years back when she noted a pea-sized neck swelling on right side, insidious on onset, which progressively increased in size and extended to left side of neck. Now present size is of 5 by 4 centimeter approximately. My patient has no history of pain over the swelling, recurrent episodes of fever or URTI, dysphagia to liquids or solids, hoarseness of voice, stridor, hemoptysis, sudden increase in size, loss or gain of weight, intolerance to cold or heat, constipation or diarrhea, tremors, palpitations, increased anxiety, visual disturbances or fatigue, irregular menstruation or menorrhagia, breathlessness, coughing or choking sensation on a lying down position, headache, sweating, palpitation, recurrent fractures or bone pain. My patient has no comorbidities like hypertension, diabetes, COPD, stroke, or any cardiac event, malignancies, seizures, or any history of previous hospitalization or operative interventions. She doesn't have any drug allergies. Family history is not significant, and obstetric history has para 2 and living 2, which both are delivered by normal vaginal delivery. My patient's appetite is normal, diet is mixed, bowel and bladder habits were normal, no disturbed sleep. My patient has no addiction of tobacco chewing or mystery user. At present, my patient is not on any medications. On examination, my patient is conscious, cooperative, and well oriented to time, place, and person. Moderately built and well nourished. BMI is of 23.4 kg per meter square. Pallor, icterus, cyanosis, clubbing, lymphadenopathy, and edema are absent. Vitally, patient temperature is afebrile. Pulse is of 75 beats per minute, regular rhythm, normal volume and character. 120 by 80 mm of Hg is the BP, which was recorded in right arm in sitting position. Respiratory rate is of 15 cycles per minute, which was regular and thoracoabdominal. 98% room saturation, 98% saturation on room air is present. On thyroid examination inspection, we will see the patient is examined in broad daylight with adequate exposure. Patient was asked to be in sitting position with head thrust backwards against the hands clasped behind the occiput. A diffuse swelling noted in anterior midline of neck. It is approximately 5 by 4 centimeter, more on right side. Suprasternal notch is visible. Skin over the swelling is normal with no ulcers, sinuses, scars, edema, or dilated veins. Swelling moves with deglutition and does not move with protrusion of tongue. There is no venous prominences over the neck or anterior chest wall. Trail sign is positive. No hand or tongue tremors present. On palpation, all inspectory findings were confirmed and patient was examined from the front. A 5 by 4 centimeter solitary midline neck swelling was present. Low border of swelling was palpable. No local rise in temperature or tenderness over the swelling. The surface of the swelling is smooth and firm in consistency. Overlying skin is not fixed. Trachea was palpable and displaced slightly towards the left. Coccus test was negative. Carotid pulsation felt normal. Berry's sign was negative. On percussion, resonant note over the manubrium sterni. There was no bruit on auscultation. Eye signs like von Graff's, Dalrymple, Joffrey's sign, Stelbach's sign, and Mobius signs were absent. On systemic examination, our respiratory system has like bilateral normal vesicular breath sounds auscultated. No added sounds were present. Bilateral air entry was equal with no accessory muscles were used. In cardiovascular system, S1 and S2 were heard with no murmurs present. In central nervous system, patient was conscious and well oriented with normal motor system and normal sensory system. Deep tendon reflexes were normal. On per abdo, soft and non-tender was observed along with bowel sounds were normal. On airway examination, no facial dysmorphic features were present. Bilateral nasal passage were patent, no DNS. Inter-incisor gap of 4 cm. Sternomental distance was 13.5 centimeters. Thyromental distance was not measured. Upper lip bite test was grade 2. Malampatti grade was grade 3. Submandibular space soft. No retrognathia. Temporomandibular joint was normal. Tongue was normal. Neck movements normal. Neck circumference was about 30 centimeter and patient had 3 missing teeth with no loose or buck teeth present. My provisional diagnosis is a 45-year female with large midline firm thyroid swelling with no signs of tracheal compression, with no hypo or hypothyroid feature, along with no comorbidities, is scheduled for total thyroidectomy.
Sir, may we start?
Yes, sir. Yes, ma'am.
Madhva sir, can we start?
Sure, ma'am, you can start, please.
Okay.
Dr. Vikrant is done with the case.
Yes. Well presented, Dr. Vikrant. Can we have your history slide, please? Firstly, yeah. Firstly, can you tell me the significance of asking the area of residence of the patient as well as the the duration you have asked? Since 3 years and it's been progressively increasing since a month, does that signify anything to you, or do you intend to extract any information from that?
Ma'am, actually, the importance of residence.
My voice is not clear.
Voice is, it's still volume is low. Can you increase it?
Yeah. Now is that clear, Vikrant?
Yes, ma'am.
Okay. So I was asking you that in your very first sentence, whatever information you've taken, how does the area of residence of the patient and the duration of the swelling matter to you? You've asked about how long it has been, how much progressive it has been in the last 1 month. The patient has come with that teeth complaint. So does that signify anything?
Yes, ma'am. As there are very many endemic areas where iodine deficiency is there. For example, in Maharashtra, areas like Pune, Kolhapur, Nashik, Jalgaon, these are the areas with low iodine. So these, because of the endemicity, there will be the more chances of goiter present. Along with the the duration of swelling matter to me because there will be tracheomalacia by the duration. If there will be more than 5 years or more longer duration is there, there are more chances of tracheomalacia for the patient.
So your area from where your patient belongs is endemic or not endemic?
My area is
Comes under endemic zone?
comes near the endemic zone, I can say. It is not, but Kolhapur, it is almost 60 kilometers from here. So that area is endemic. So my area is near to that zone.
Okay. Coming to the next slide. Have you tried to rule out whether she has any symptoms of hyper or hypothyroidism?
Yes, I
I think
asked
you
the
have.
patient about loss or gain in weight, intolerance to heat, constipation or diarrhea, tremors, palpitation, which denotes hyperthyroidism and hypothyroidism. For example, in hypothyroidism, I will get the history of palpitation or angina. There will be sleep disturbances, tiredness, or there will be heat intolerance or weight loss, diarrhea, warm and moist skin, and oligomenorrhea. While in patients with hypothyroidism, the patient will complain of BMR will be decreased. So there will be cold intolerance, weight gain, constipation, cold and dry skin with irregular menstruation.
So from your history, your patient does it look hypothyroid or clinically euthyroid? From your history,
Ma'am, there are no symptoms of hypo or hyperthyroidism. I can say that patient is euthyroid according to the symptoms.
okay. And okay, pain over the swelling, recurrent episodes of fever you are there. Why have you asked that?
Because ma'am, most of the cases have repeated viral infections. So because of repeated viral infection, there might be chances of thyroiditis. So that's why I asked for recurrent episodes of fever.
Have you ruled out any chances of this being a malignant nodule?
Yes, ma'am. As in malignancy, there will be sudden increase in size of swelling as well as hemoptysis, which can denote the malignancy. So I asked that so that they can give my slight denotions that malignancy will not be there, along with sudden loss of weight will be there in malignancy.
What else can you rule out, especially if you are
Uh,
suspecting a thyroid malignancy?
Ma'am, I will ask for another symptoms like if there is any headache, sweating, palpitation, recurrent pathological fractures are there or not, and uh, these things I can ask to
Okay.
rule out the malignancy. Like
What will they tell you? What will a recurrent pathological fracture suggest?
there can be parathyroid adenoma, which I can rule out. Parathyroid adenoma or parathyroid hyperplasia. And with the headache, palpitation, sweating, and like increased BP, I can rule out pheochromocytoma, which combine to form men to A.
Okay. What does men 2 syndrome include? Men 2A, men 2B.
Yes, ma'am.
What do they
Men 2A
comprise
and
of?
men 2B. Men 2A and men 2B. Men 2A consist of pheochromocytoma, parathyroid adenoma, and medullary thyroid carcinoma, while men 2B consists of pheochromocytoma, medullary thyroid carcinoma, and neuromas.
Where does thyroid malignancy show met most commonly?
Ma'am.
Where does thyroid malignancy tend to show met most commonly?
Most commonly on bone and lung.
You've possibly taken all those bony history as well as hemoptysis. Okay.
Yes, hemoptysis and bony pain I should have asked, but bone pain was not there.
Next,
Recurrent pathological fractures were not there.
okay. Next slide. Next slide. Did the patient have any drug history?
No, ma'am, patient is not on any medication at present.
Do you know of any drugs that can cause any thyroid disturbance?
Ma'am, drugs like amiodarone or lithium may cause disruption in thyroid hormone synthesis, which can lead to hypothyroidism.
Excuse me, Dr. Shraddha, your voice is breaking in between and it's quite low. Can you please adjust your mic?
Wait. Yeah. Is that audible to you all now?
Yeah, it's better now. Thank
Is
you.
that better? Yeah.
Yeah.
Okay. So you have ruled out any drug history that the patient is on.
Yes, ma'am.
Okay. Okay, next. Can you show the next slide, please?
Ma'am, voice is
Okay.
less only.
अजूनही येत नाही? Hello?
व्यवस्थित हा.
Okay. Okay, next.
हा.
Okay. Kanseban, do you want to add anything on this?
Please unmute yourself.
Okay.
Yeah.
General examination, what are the, you have taken general examination as patient is conscious, cooperative. Can you, why have you taken this specifically? Any specific to any pertaining this thing?
Ma'am, as thyroid may cause any irritability or
Thyroid or
there,
hyper, or which other condition? Why is it significant? Patient is conscious, cooperative, oriented.
like there is a condition in hypothyroidism, myxedema, coma. If the patient is presented with unconsciousness or comatose situation or a severe bradycardia, I might say that patient has untreated hypothyroidism for longer duration.
And also if the patient has hyperthyroidism, you will have other symptoms like patient will be restless,
Restless, yeah.
anxious, irritable. Okay.
Irritable, yeah, yes, ma'am.
And
Patient will be
continuously moving, he won't be stable.
agitated. Patient will be there.
Agitated. So the general examination is also equally important in ruling out certain signs of hyper as well as hypothyroidism.
Hypothyroidism.
What about the pulse? What do you know about sleeping pulse rate?
Ma'am, sleeping pulse rate is a pulse rate which we take in the midnight or 2 hours before the scheduled time of awakening. The sleeping pulse rate, if the patient has more than 90 beats per minute, I can say the patient has tachycardia, which can correlate with the symptom of hyperthyroidism.
So even when the patient comes to you for pre-anesthetic checkup, he may be anxious.
Yes,
He may be scared. So even at that time, his pulse rate could be on higher side. So
yes,
if you want to rule out hyperthyroidism, you can definitely go in the middle of the night or when the patient is in deep sleep and palpate his pulse, or if he has slept late, you can go 2 hours before he gets up
yes, sir.
in the middle of the night and see for his pulse rate. Fine. In other examination, can you go to the next slide? Can we go to the next slide? Yeah. What are the different methods of thyroid examination? Do you know of any other methods?
Ma'am, there are 2 to 3 techniques like Pizziler's technique, layman,
Increase your
Leahy's
volume,
technique.
Vikrant. Your volume is low. Little increase.
Ma'am, am I audible?
Yeah.
Ma'am, there are 2 to 3 techniques like Pizziler's technique, Leahy's technique, and Kryle's method.
Can you explain it?
Ma'am, Pizziler's technique in which the patient, the thyroid is checked with the while asking the patient is asked to put his both the hands on the occiput while the head is forced or thrusted back on the clasped hands. That makes the thyroid more prominent, which will help to examine it. While in the Lahis technique, there will be we will ask the patient to push the thyroid gland with the, say if the patient's left side is being monitored, then we have to push the thyroid on with our left hand, and we will be it will be examined with on the from the back of the patient, and which is important to see the margins of the thyroid gland.
What are the methods?
Cryos technique is there. Cryos technique is used to like the where we will put our thumb on the thyroid gland, and we will ask the patient to do the deglutition action, in which we can able to palpate any nodules are present or not on the gland.
What do you mean by trail sign is positive?
Trail sign means, ma'am, where when the trachea is displaced to a side, the on that side the clavicular head of sternocleidomastoid it gets more prominent.
Uh, there are no venous prominence over the neck and the chest wall. What does it indicate? Why have you taken this specific
Ma'am,
this?
because there is vena cava obstruction, superior vena cava obstruction in that because of any mass over like large thyroid mass, if any compression over the superior vena cava or retrosternal mass any compressing over superior vena cava, there might be the chances of uh, prominence of venous prominences over the neck and anterior
So if
chest
there
wall
is
along with the flushing of the face.
if there is a retrosternal extension of the thyroid gland, and if it's causing SPC obstruction, then you will have dilated veins over the anterior
Anterior
chest
chest wall
wall,
and neck.
neck, right?
Yes, ma'am.
How did you elicit the hand tremors?
I will ask the patient to raise the hand in front of him with the fingers, stretch the hands with the fingers fanning, and I will keep one paper on the fingers so that if there are any tremors, I will able to elicit it.
What is the other differential diagnosis of thyroid gland which you have tried to eliminate? Anything in your inspection? You have specifically asked, you have said it doesn't move with protrusion of tongue. Why did
Yeah,
you write
ma'am,
that?
I will the thyroglossal cyst is attached to the protrusion of tongue. It is attached to the base of tongue. So while protrusion of tongue, the thyroglossal cyst will move, but thyroid gland will not move as it is attached to Berry's ligament and it is attached to thyroid trachea. So after, only during deglutition, the thyroid will move.
What about the tongue tremors? What tremors are they called as?
Ma'am,
So if you want to see for fine tremors, you should look at the
tongue tremors.
tongue. Ask the patient to what? How will you ask?
Ma'am, I
What
will
will
ask the patient to close his eyes and I will ask him to stick the tongue out so that any fine tremors are there, it will be visible.
next slide? What is Cocker's test? How will you elicit? And what is
Uh,
Berry's sign is negative? So at least clarify your exam palpation signs.
Ma'am, Cocker's test is basically it is to see the patient has any stridor or not, which will able to we have to palpate the thyroid gland with, on the lateral border, which will elicit if there is a stridor or not. If the stridor is present, there means their trachea is compressed because of thyroid gland. And Berry sign is we have if we able to palpate any pulse, the carotid pulse there or any pulsation that tells us that there is increased vascularity.
No. Berry's sign is you can negative means carotid pulsations are
Not
felt or not
palpable.
felt.
No, carotid pulsations are not palpable. If they are palpable
It will be
in
positive.
malignancy,
Not palpable, it will be positive.
yeah,
Negative means carotid pulsations are palpable. That means that the carotid sheath is not engulfed in the
carotid in the malignancy,
thyroid swelling,
infiltration.
right? So carotid pulsations are felt separately
Yes.
on both the sides. Next slide. What are the eye signs? Can you elaborate a bit about the eye signs? Why did you see for the resonance for the this thing percussion on the manubrium sternum? What is the significance of each and of your examination? Can you answer?
Ma'am,
You have just written it, but why you have done that? What will it tell you? Resonant note over the manubrium sternum. Why did you percuss the manubrium?
Ma'am, because if there is a retrosternal mass, there will be a dull note present on percussion. As there is resonant note, we can say that the retrosternal mass will not be there, might not be there.
There is no retrosternal extension of the thyroid gland.
Thyroid gland.
What about the auscultation? No bruit. No bruit over what?
No, it tells us that there is no increased vascularity in the thyroid gland.
Okay. Can you just expand the eye signs? What will you look for in the eye signs?
Ma'am, eye science basically tells us about the Graves disease generally, and Von Graffis. There are like many signs, but 5 signs are like Von Graffis signs, which tells us about. We will ask the patient to suddenly look downwards. The upper lid lags behind in the eyeball. We can see the upper palpebra, which tells us about Von Graffis signs is positive. Next sign is Dalrymple sign, which is wide palpebral aperture. The sclera is visible even above the iris. The next is Joffre's sign, which is absent wrinkling. The patient looks upward when the head is fixed. There is absence of wrinkling on the forehead. The next is ma'am Stilwell's sign, which is absent blinking. The infrequent blinking results into a staring look. And Mobius sign, which is absence of convergence. There is lack of convergence of the eyeball. These are the signs which are characterized of Graves' disease, ma'am.
So in Dalrymple sign, actually, when you sit in front of the patient, these are the signs we will see in Graves' disease. So in Dalrymple sign, what happens is the patient, when he sits in front of you, you get a starry look. And you can see the palpebral sclera and the corneoscleral limbus, you can see. So normally the sclera above the cornea is not seen in normal people, but in Graves' disease, it is seen. Similarly, in Von Graffis sign, when you ask the patient to look down, the cornea goes down, but the lids do not move downwards, and there that time also you can see the palpebral sclera above the cornea. Joffre's sign is absence of wrinkling. Make the patient flex his neck and look upwards. So when he looks upwards, normally we have blinking on the forehead, but in these patients you will not see blinking in the wrinkling of the forehead. And as you said, patient really has absence of blinking. And Mobius sign, like when you ask the patient to follow his finger and take it near his eyes, there is absence of convergence. So these are the eye signs you see in Graves' disease patients.
Yes.
Next. What is the significance of deep tendon reflexes?
Ma'am, deep tendon reflexes are delayed in hypothyroidism, while they are very brisk in hyperthyroidism. So this sign.
So next. Okay, next. So when you give a provisional diagnosis, what all you are supposed to cover in the provisional diagnosis? That is, as we have written, age of the patient, sex of the patient, gender of the patient, about the swelling, whether it has any tracheal airway obstruction like tracheal compression, with or without tracheal compression, with or without any signs and symptoms of hyper or hypothyroidism, and whether there are any with retrosternal extension, with or without retrosternal extension, and with any associated comorbidities.
Yes, ma'am.
And what the patient is posted for, what type of surgery the patient is posted for. So in short, can you just elicit the negative history and examination points, symptoms and signs, which you have tried to take to rule out hyper and hypothyroidism? Can you just elaborate fast? These are the signs I have elicited, or the symptoms and signs for hyper and hypo.
So, ma'am, in hypothyroidism, there will be gain of weight with in hypothyroidism. There will be gain of weight, cold intolerance. Then, other than that, there will be constipation, irregular menses, and we can see in because that is because of decrease in metabolic rate. While in hypothyroidism, in neurological science, if we see, there will be forgetfulness, depressed mood, slow and clumsy speech. Also, there will be bradycardia. But in hyperthyroidism, there will be palpitation and angina in severe system. In neurological, there will be sleep disturbances, tiredness, nervousness, and metabolically, we see the patient will be have heat tolerance, weight loss, oligomenorrhagia, and diarrhea. The skin will be moist and warm. While the signs in hyperthyroidism will be increased in CVS, we can see increased heart rate, tachycardia, arrhythmia. There will be deep tendon reflexes will be brisk. Other than that, blood will be having anemia, granulocytopenia, or decreased platelets. And in hypothyroidism, there will be bradycardia. Along with in RS system, we can see reduced ventilatory dive. This can lead to hypercarbia. Also, there will be hyponatremia, anemia. There will be factor 8 and 9 will be decreased. That's why it can cause the blood coagulation profile is deranged.
So each and every point which you have taken in your history and in your examination has significance, right?
Yes,
Right from even in, as we have said that pulse rate is so and so, it is regular, volume, rate, rhythm, volume, bilaterally equal, whether there is any delay, radiofemoral delay. Because in both in hypothyroidism, you have tachyarrhythmias, atrial fibrillation. In hypo, you can have bradyarrhythmias. So each and every point which you have taken in your history has some significance, and it rules out one or the other condition, right? Can we go for the investigations? Shraddha, over
Yes.
to you.
Yeah. Vikrant, before that, also there's a query in the chat box. So, are you aware of Pemberton sign?
Yes, ma'am.
Did you elicit it?
No, ma'am. I didn't elicit it because it has a disadvantage that when we ask to elicit that Pemberton sign, there will be decreased blood supply towards the brain, which can cause faintness, and we can lead to more damage to the brain. So we will ask to elicit the sign. We ask the patient to raise his hands above his head, but if the patient is like what patient is asked to raise his hands above vertically over the shoulder till they touch the sides of the hand and hold his breath for inspiration for 1 minute. But there patient experiences faintness, facial congestion will be there, increase in plethora over the face, engorgement of neck and veins. It implies there is a superior vena cava syndrome due to retrosternal goiter compressing on the mediastinal vessels. So, but because of the faintness and all that, and because we have many other tests like CT scan, USG, CT scan is gold standard. So, I avoided to elicit the Pemberton sign.
Yeah, so this Pemberton sign is to elicit your retrosternal extension of the thyroid gland.
Yes, ma'am.
And nowadays, usually patients come with CT scan and MRI to us of the thyroid of the neck. So usually Pemberton sign is not needed or not done for to prevent any this thing.
Faintness or brain injury.
So, how will you go about investigating this patient now that he's posted for total thyroidectomy?
Ma'am, आवाज ma'am.
So that was
how will you go about investigating this patient now that he's posted for total thyroidectomy?
I will prescribe the investigations like CBC, as patient might present with anemia, and TLC counts will be decreased because of granulocytopenia will be there. Platelet aggregation adhesiveness will be decreased. That's why platelet count is necessary. Sugar level monitoring I will do because hypo and hyper both have like symptoms like hypoglycemia and hyperglycemia. Coagulation profile because of decreased in factor 8 and factor 9. Then again I will go with serum calcium levels because of to see any parathyroid disorders. Other than that, I will go for RFT as a routine examination and LFT as there is increase in serum alkaline phosphatase because of in hyperthyroidism. Along with it, I will go for serum electrolytes because there is decrease in sodium in hypothyroidism and decrease in potassium in hyperthyroidism. Also, I will go for chest X-ray to find any other comorbidities present or not. And if there is deviation or compression of trachea, I can find it through X-ray neck and AP and lateral. Along with, I will ask for ECG to see if there is any bradyarrhythmia or tachyarrhythmia or any signs of atrial fibrillation. Uh, Nowadays, with the advanced technology, I will ask the patient to do USG, CT scan, and indirect laryngoscopy because it has medical legal importance. Along with it, IDL can tell us about there is any vocal cord palsy is there, any recurrent laryngeal nerve involvement is there. Uh, then I will ask for thyroid function test in which TSH, free T3, free T4 is more preferential than total T3 and more total T4.
Okay. What information are you expecting or you want to extract? What information do you intend to extract from a CT scan if the patient has come with a CT neck or you are ordering for one?
Ma'am, CT scan tells us about actual diameter of the trachea along with if there is any compression or deviation. And it can tells us very prominently about retrosternal extension of thyroid gland.
Also, it will tell you the exact level of tracheal compression if it is there,
Yes, ma'am.
so that you exactly know what difficulty at what level you're going to probably
And it
encounter.
can help us to find the ET tube number, that size we can put during intubation.
Okay. What are the normal thyroid levels? T3, T4, TSH?
Ma'am, TSH is 0.5 to 5 milli international units per liter, while total total T4, T3 is 1 to 3 microgram per liter, with T4 is 50 to 200 micrograms per liter. Free T3 is 3 to 8 picomole per liter, and T4 is 10 to 30 picomoles per liter.
So now suppose if this patient is a hyperthyroid patient, he has a high T3, T4, and he comes for a surgery to you. So what will your approach be?
Ma'am, if the patient has to elective surgery, I will ask the patient to postpone the surgery by 3 to 4 weeks more, because I would like the patient to come and euthyroid state. If the patient has semi-urgent type of surgery, I will postpone the surgery till 14 days and I will start medications. And in emergency surgeries, I have to take with another medications. For elective surgery, I will ask the patient to start on antithyroid drugs and iodine for antithyroid drugs like propylthiouracil and methimazole, and I will start the patient on iodine for 13 to 14 days prior to surgery. While in semi-emergency surgery, again I will ask the patient to take antithyroid drugs along with iodine for 10 to 12 days prior to the surgery. And in the emergency surgery, I will manage the case with like I have to manage the symptomatically I have to manage, as well as cause I have to manage. So I will start with antithyroid drugs as well as symptomatic drugs like propanolol and esmolol, and manage the case.
So does propranolol have a role in elective surgeries as well? Because you did not mention there.
Yes, ma'am.
When you
Propanolol
are
has
starting antithyroid drugs, are you doing anything for the rate control as well?
yes, ma'am. Antithyroid as well as rate control.
Okay, so this patient comes in for a let's say emergency surgery and you take up. So, and he lands up, how will you know that he's about to land up in a probable thyroid storm? That makes him at risk to develop a thyroid storm, isn't it?
Yes, ma'am.
If you're taking an unoptimized patient for an emergency surgery for whatever reason, your most important concern probably is that he might land up into a thyroid storm.
Ma'am, if the inadequately managed patient and the stress and undiagnosed thyroid hormones there are probable chances that patient will land up into thyroid crisis or thyroid storm. I will detect the patient if the patient has sudden tachycardia or increase in EtCO2. There is a sudden increase in temperature. I will get to the diagnosis of thyroid crisis or thyroid storm.
Okay. And If that happens, what will you do?
Ma'am, if the thyroid crisis happens intra-op, I will ask the surgeon to stop for the surgery, and then I will ask that I will treat the cause and treat the symptom. I will treat the cause by giving propylthiouracil, antithyroid drugs like propylthiouracil 100 to 200 mg, and or methimazole, and I will treat the cause by giving cold IV crystalloids to decrease the temperature of the patient. Rate control to decrease to control the rate, I will give propranolol around 0.5 to 3 mg IV for every 2 minutes, or I will start the ismolol, which is around 50 to 200 micrograms per kg per minute. Again, I will give hydrocortisone 100 to 200 mg, and potassium iodide or sodium iodide I will start IV. If anything doesn't work, then I will ask for therapeutic plasma pheresis.
Coming back to investigation, what is the role of flow volume loop?
Ma'am, in flow volume loop will tell us about intrathoracic and extrathoracic obstruction. For example, in extrathoracic obstruction, there is narrowing of trachea during inspiration, but during expiration, the airway maintains the patency. That means there is inspiratory loop will be flattened during extrathoracic obstruction, while in intrathoracic obstruction, as there is a pleural pressure will be positive, during expiration, there will be narrowing of intrathoracic airway during expiration. So expiratory limb will be flattened during intrathoracic obstruction. But if there is any fixed obstruction, we will able to find there is flattening of intrathoracic as well as extrathoracic obstruction.
Okay. So what is the plan? What is your plan of anesthesia in this particular patient?
Shraddha, he has forgotten indirect laryngoscopy also. Is it important?
Ideal, he said, I think. Ideal, he told, I think.
Ideal medical legal importance as that.
He mentioned, I think. You mentioned, right?
Yes, ma'am.
He mentioned.
So in this patient, what is his plan of anesthesia? Like this patient with this size of the swelling, how would you go ahead with your, what is your plan? How will you induce this case?
Ma'am, as this patient doesn't have any compression or compression signs and symptoms, I will start with the pre-medication, which consists of proton pump inhibitor, pantoprazole. I will 40 mg. I will give up, and after that, I will start with the benzodiazepine. Then short-acting opioids I will use like fentanyl, 1 to 2 mics per kg, and I will start with the IV induction agents like thiopentone and propofol. I will after induction, I will intubate the patient and put the patient under controlled ventilation.
Vikrant,
What?
once the plan of anesthesia is asked to, you can elaborate surely, but in a line, if you could present that what exactly is your plan in one line, and then we can elaborate on that. That makes it easier for the examiner to understand what lines you are thinking of. And then we can proceed of how one by one, stepwise, you'll do it. So, because especially in thyroid, there are a lot of methods which you can opt for. There could be inhalational, there could be IV, you could opt for a fiber optic, depending on situation. So what is your plan?
For
if
this
you could
patient,
summarize and then we can elaborate.
Yes, ma'am. For this patient, I will use intravenous induction with controlled ventilation.
Muscle relaxation?
Yes, ma'am. Muscle relaxation, I will use, ma'am.
Now, if the size of this swelling was still more than what you have it now, if it's a big goiter, what would your plan change?
Yes, ma'am. My plan will be awake fiber optic intubation.
What are the signs which will make you change your, if it's a massive swelling with certain signs, okay, signs and symptoms, only then you will go for fiber optic, right?
Yes, ma'am.
So what would you look for?
If there is any signs of tracheomalacia, or there is obstruction and compression of the trachea due to thyroid gland, if there is any retrosternal extension of thyroid gland, then I will go for awake fiber optic intubation.
If there is any stridor, right? If there is any history of stridor, when specifically when the patient lies down supine and then he has a stridor, the stridor increases. So that means there is obstruction, right?
Yes,
swelling is compressing the trachea. If it's more than 50%, So that is the time of when there's hoarseness of voice, when you feel that the trachea has been invaded by the tumor. That is the time, and with big mass, right? Big,
Yes,
huge goiter. That is the time when you will decide your plan of anesthesia will change. So in such patients, what would you go for? What would be your plan?
If there is any compression or obstructive symptoms, I will go for awake fiber optic intubation.
Vikrant, that reminds me that in the history you haven't asked the patient whether he gets breathless in the recumbent position.
Yes, ma'am. I asked about
Even
the
I forgot
breathlessness.
asking you, but now that we have come to this point, I realize you're probably not asked.
Ma'am, I asked about breathlessness, coughing or choking sensation on lying down position, ma'am.
Okay, we asked. Okay. So he did not have any sign. Your patient did not have any sign.
Yes, ma'am. Yes, ma'am. That's why IV induction agent was my choice, ma'am.
Okay.
Now,
So
if
if
this
the patient has this symptom, then what you're going to do, as madam asked you?
Ma'am, if the patient has breathlessness or choking or coughing sensation, I will first ask in which position he is comfortable to sleep. Because while induction, if I'm not able to ventilate the patient, I will make sure that patient is in that position. Or otherwise, I will ask my assistant to hold the thyroid by a towel clip or something, and hold up the thyroid, so that it will be easy for me to ventilate the patient.
No, by that I meant that if you have a large thyroid mass, which is probably having obstructive symptoms, what will be your basic plan of anesthesia? Like you said, now you'll have an IV induction. If the mass was big and obstructing, what would have done?
Ma'am,
fiber optic, I think.
I would have used IV not IV, but I have used inhalational agent of anesthesia. Inhalation induction.
inhalation, when if your fiber optic is not available, everywhere it may not be available. So if the fiber optic is not available in the institute, you can definitely go for inhalation anesthesia for induction.
So if you choose inhalation, would you like to give muscle relaxant once your patient is under, or would you like to go for a spontaneous intubation?
Ma'am, I would like to go under spontaneous respiration. I would like to intubate under spontaneous respiration, because after giving muscle relaxant, there might be chances of the thyroid gland compressing over the trachea.
So you have to mention, it is a large thyroid gland. Your ideal choice, if not fiber optic, will be a inhalation induction
under spontaneous breathing
and with spontaneous ventilation. At least till your tube is secured.
Yes, ma'am.
Okay. So what are your other intraoperative concerns? What monitoring you are going to instill in this patient?
Ma'am,
and what will be your intraoperative goals? Now that you have induced intraoperative goals of management.
Yes, ma'am. My monitors I will use that are pulse oximeter to see the saturation and pulse rate, NIBP, non-invasive blood monitoring. I will go for invasive blood monitoring if I suspect any higher chances of bleeding is there. Then I will go for ECG. Other than that, ETCO2 monitoring will be there, and nerve conduction if it is available. Now condition monitoring. Other than that, I will go for BP pulse rate.
Something more
temperature.
Important something important.
Temperature monitoring.
Temperature monitoring, ma'am. Yes, ma'am. Temperature monitoring. I will go for temperature monitoring. Nasal probe I will use for that.
If this patient is, if the patient is hyperthyroid now and posted for some other surgery, so what would be your anesthetic consideration in a hyperthyroid patient posted for other surgery? What are the precautions you will take during the anesthetic, intraop anesthetic precautions in a hyperthyroid patient posted for other surgery, non-thyroid surgery?
Ma'am, I will make sure that patient is in the condition of euthyroid or not. If the patient is in euthyroid state, then if the patient is in emergency surgery, then I have to make sure that I will make sure that patient is taking antithyroid drugs.
What I wanted to ask you is, what are the precautions? The hyperthyroid may not be very severely hyperthyroid, but posted for an emergency surgery. So what are the anesthetic consideration or precaution you will take intraoperatively? Certain drugs which you will not use or you will prevent or avoid in a hyperthyroid patient.
Mm,
So round around it comes to the same question, Vikrant. What are your intraoperative concerns and how will you manage them? What are your concerns? What would happen? How will you avoid that? You will use some drugs, you will not use some drugs, whatever.
Ma'am, in like hyperthyroid patient, I will not induce the patient on ketamine. I
Yes.
will more use
Induce
thiopental
with
for
pento. Yes.
induction. Also, I will make sure that patient, if there is any tachycardia or
Is there any advantage of thiopentone in a hyperthyroid patient? Any other advantage besides induction agent?
ma'am, it decreases the peripheral conversion of T4 to T3, ma'am.
Okay. What about the other drugs? Yes.
Ma'am, other drugs like Propofol is cardiostable. So I can use that. Ketamine we can't use in hyperthyroid patient, but it is we can use while induction in hypothyroid patients because of
Okay.
its sympathomimetic action.
What about atropine glyco?
Ma'am, in pre-medication, I will avoid the pre-medication in hyperthyroid patient, and it can cause more tachycardia.
What about muscle relaxants?
Muscle relaxant, I can use vecuronium, atracurium, and cisatracurium, both and hyperthyroid as well as hypothyroid.
If there is
But
hypotension in these patients, what would be your drug of choice?
I will go for ma'am phenylephrine, but not ephedrine or adrenaline containing drugs like noradrenaline and adrenaline. I will not use.
So avoid adrenaline containing drugs in these patients. Now the same patient, if he is hypothyroid and posted for surgery other than thyroid surgeries, so similarly on the same this thing, how will you manage a hypothyroid patient?
In hypothyroid patient, ma'am, as there is
Right from induction, your maintenance and till your extubation.
yes, ma'am. In hypothyroid patients, as there is less blood volume and less cardiac output is there, less stroke volume is there, hypothermia, glycemia, everything is there. So I will make sure that I will give titrated dose of drugs, as there because of decrease in basal metabolic rate. There, I will use. I will avoid benzodiazepines or any anxiolytic drug before the day of surgery. I will use very less quantity of drug, and I will observe. I will titrate and give the drugs so that I will not end up in giving more drugs because of the decrease excretion of the drugs. That's why.
So all these hypothyroid patients, they are hyponatremia. They have hyponatremia, hypoglycemia, hypothermia, hypovolemia, adrenocortical insufficiency. They may have anemia also, right?
Yes, ma'am.
So
Yes, ma'am.
accordingly, you have to maintain the induction intraoperatively. Also, if there is hypotension, what is the drug of choice in these patients? Ephedrine.
Ephedrine,
More
ma'am.
than
Yes.
phenylephrine, right? So you have to intraoperatively, you have to maintain the body temperature, prevent hypothermia in these patients. Also, there is a hepatic metabolism of all the drugs are reduced and sluggish. So you have to give titrated doses of all the intravenous as well as muscle relaxants. You have to use neuromonitoring.
Yes, ma'am.
Right?
Neuromonitoring. Yeah.
Is
Muscle
must in
relaxants.
these patients. So how will you, what about extubation in these patients?
Ma'am, during extubation, I will make sure that the patient is on spontaneous respiration, as well as patient is not having any edema, laryngeal or tracheal edema should not be there. I will see the leak test for extubating the patient. Then
Why will you see the leak test and how will you do it?
ma'am, leak test is to see any laryngeal or tracheal edema. If the I will keep the patient on IPV mode, but on spontaneous IPV mode, and if the patient is having leak,
Do you intend to see laryngeal edema with the leak test?
tracheal edema, ma'am.
Is it?
Tracheomalacia and tracheal edema will be there.
Edema. Okay.
So, ma'am,
What will
I
it tell you?
will
What
keep
will it tell you? Leak test tells you what?
Ma'am, leak test tells you that is there if the leak is present, that means leak test is if the leak test is present, that means leak is negative. Leak test is negative, which tells us that we can't extubate as there is a block because like
So the leak should be present or the leak should not be present. What is the good news?
leak should be present, ma'am. If the leak is present, there is area. We should actually remove the air in the cuff first, and if the leak is present, there is area to exchange of gas. So if there is exchange of gas is happening around the tube, that means leak is present, and which is good because even we extubate the patient, there will not be any problem for maintaining the patency of the airway. But if leak is absent, there might be the chance of tracheomalacia or laryngeal vocal cord palsy or edema might be there.
I don't think your vocal cord palsy will be caught in the leak test. Tracheomalacia, I accept.
Tracheomalacia, ma'am.
If you're suspecting tracheomalacia in this patient, for instance, there is no air leak on deflation of the cuff, right? And you feel there is no air leak, there might be tracheomalacia. How will you extubate this patient?
Ma'am, I will not extubate the patient if I suspect there is tracheomalacia. I will keep the patient ETT in situ, and I will after 24 to 48 hours I will again do leak test. If the again leak test comes positive, if there leak test comes positive, then I will extubate the patient. But immediately I will not extubate the patient.
And if you want to extubate, how will you extubate also?
Ma'am, I will
Over
keep
what?
the emergency intubation trolley with me. In that emergency trolley, I will keep everything ready for re-intubation of the patient, ma'am.
But then your airway has collapsed. Then how will you re-intubate?
What will you use?
You remove the tube, it is all up. Then now what will you do?
So will you use something else during extubation? That's what she's giving you a hint.
See, your airway is totally collapsed. So you have everything at hand, but you can't put the tube in. Then what to do?
If airway is totally collapsed,
You give it some chance that in case something happens, you can put it back. What will you do?
I will put the bougie and I will extubate the patient, ma'am.
Okay. Anything else?
Okay, some better version of bougie.
Can you use fiber optic bronchoscope
probably ventilate
for the tube?
We can probably ventilate with air exchange catheter or something.
Yes, ma'am. That exchange catheter I will use, ma'am, while extubating, or I will see
If you don't have a fiber
I will
optic.
do the fiber optic bronchoscopy to see if there is any weakness of tracheal wall or not.
Very good. So you will see, you will have a visual image of whether the rings
Yes, ma'am.
appear doubtful to you, or even if you can keep the FOB in place, pull it up above the cord. Something happens, you can just push it. You can pull the tube out above the cord. Your FOB can still be there, and if you find something is wrong, can put it back. If you don't have a FOB, at least you can use a ventilating bougie or airway exchange catheter. Those are easily available everywhere.
Yeah, okay.
Isn't it? So you have some time to buy if some catastrophe happens, isn't it? Okay. I could see one query in the chat box, Vikrant, if you could elaborate. They said, somebody was asking, I just happened to read, that you need muscle relaxants for intubation. But how will you intubate if you avoid them? Somebody was asking. You have already elaborated. If you could explain them, why you don't want to use muscle relaxant in the large thyroid mass. And can you actually intubate without a relaxant?
Shraddha, can you only elaborate so we can save some time? Elaborate it. You only explain it.
So somebody was asking me this. See, I agree that you will have an ideal intubating condition, but when your mass is large, you probably have history of obstructive symptoms already. So there are large chances, there are huge chances that when you relax that kind of patient after induction, the mass is going to fall off and totally compress your trachea, leading to a complete airway collapse, which can be catastrophic. Instead, if you maintain the patient's spontaneous breathing, the airway patency will be maintained. And of course, we can take him deep under sevoflurane, and maybe we can give some supplementary propofol. We can take him deep, check his ventilation, and do a chexcopy as well as intubation under spontaneous respiration also. So we will not have an airway catastrophe, more so when he is having obstructive symptoms, and the large chances that with the muscle tone being gone after your relaxation, the mass will completely fall off over your trachea, and it will be could be a dangerous situation.
Yes, ma'am.
Yes, choline can be tried. Somebody was asking. Choline can be tried, but then even under choline, that mass might just simply fall off. You'll be lucky if you get pull it off, or you can save the situation by putting him in a lateral position or give him time till he breathes spontaneously. But I think if the mass is large and you already have symptoms, it is always safe to keep the spontaneous breathing of the patient intact till you secure the airway.
Yes, so when there is a large mass, you should always have an extra hand. So while intubation, if there is a big goiter, somebody can lift the person other than the person who's doing scopy can lift the mass up, so you can pass the tube. Now, can we go to the complications?
Yes.
What about the complications?
Ma'am, complications can be immediate.
Divided into how? You have to divide the
Complications can be immediate or early or late complications, ma'am. In which immediate we can see respiratory obstruction due to hematoma, airway edema, laryngeal edema, tracheomalacia, or because of tight bandage over the neck also the patient will find respiratory discomfort. While in early complication, which can occur with between 24 to 48 hours, can be recurrent laryngeal nerve palsy, in which incomplete bilateral recurrent laryngeal palsy is more dangerous because of there will be unopposed action of adductor muscles, which can lead the patient into respiratory distress. There also thyroid crisis or thyroid storm might occur within 24 to 48 hours. And parathyroid insufficiency also we can see in some patients, in which patient can present with anxiety, mental depression, paresthesia, and laryngeal spasm, tetany. And in late complication, we can see the complications of again hypoparathyroidism and hypothyroidism.
Now, Vikrant, immediately after post-operatively, the surgery resident calls you up. That patient is having stridor and the saturation has started falling. What would be your provisional diagnosis and how will you manage that case?
Ma'am, I will see if there is first of all, I will see there is any hematoma over surgical site is not there or not. If there is any hematoma, I will because of that hematoma compressing over the trachea, there might be respiratory distress. So I will always keep tracheal suture removal tray besides the patient, and I will cut the alternate sutures of the patient and relieve the hematoma.
If the patient is taken, what could be the other cause of tracheal airway edema in this patient? So even the hematoma can be obstructing the lymphatics and the venous drainage of the tracheal mucosa, which can also lead to tracheal mucosal edema in this patient. So that could be also one of the cause for stridor in these patients. Now, if this patient is again taken in the operation theater, what would be your concerns?
Ma'am, my concerns will be that the airway will be definitely difficult because the patient already was intubated by me only, and again if the patient is coming for the OT in a few hours, then the airway will be difficult and the prior intubation. Other than that, there will be compression because of compression or edema, airway edema more. So it might be the difficult intubation.
Difficult intubation, edema, airway edema. Also, patient may be in hypotension, right?
Yes, ma'am. If the patient had hematoma or bleeding tendency of the patient, can land up the patient into hematoma.
Somebody had asked what is the differential diagnosis of thyroid storm? That is malignant hyperthermia, neuroleptic malignant syndrome, and pheochromocytoma. Right?
Yes,
Excuse me, shall we take up the questions now?
Yeah. We are almost through.
Okay. So shall I wait for some more time or we'll start taking it now?
Vikrant, can we quickly discuss laryngeal nerve palsy and then we can take a question?
Yeah.
Ma'am, laryngeal nerve palsy, like there will be a superior laryngeal
Okay,
nerve
tell me
and
which is the most dangerous. Tell me which is the most dangerous. and why.
bilateral partial recurrent laryngeal nerve, ma'am. Because of there will be no opposed action of adductors, abductors. There will be adduction of the vocal cords, which can lead to severe respiratory distress. But in complete
And what?
But in complete recurrent laryngeal nerve palsy, there is glottic opening will be like there will be patent airway, but there is the vocal cords will be in the cadaveric position. So at that time, gaseous section is possible, but there is chances of aphonia and high chances of high risk of pulmonary aspiration.
Should we? Okay, tell me the nerve supply of this vocal cord. Quick, we have to take questions.
Yes, ma'am. Nerve supplies that superior laryngeal nerve and recurrent laryngeal nerve. Above the vocal cord, there is superior laryngeal nerve, external branch and internal branch, in which only cricothyroid is supplied by.
Sensory, motor. Sensory and motor.
Uh,
Sensory supply, motor supply.
Ma'am, sensory is with the internal laryngeal nerve and above the vocal cord, and sensory below the vocal cord is by recurrent laryngeal nerve, and motor supply above the vocal cord, cricothyroid is supplied by superior laryngeal nerve, external branch, while all the other muscles are intrinsic muscles are supplied by recurrent laryngeal nerve.
Yes, so all the muscles are supplied by recurrent laryngeal nerve except for the
Except cricothyroid.
cricothyroid muscle, which is supplied by the external branch of the superior laryngeal. Correct. And above the vocal cords, all the sensory supply is by superior laryngeal, and below the vocal cord, the sensory supply is by recurrent laryngeal.
Yes, ma'am.
Correctly said. Nice.
Good job, Vikrant. Monica, maybe we can take some questions.
Yeah, sure, ma'am. So congratulations, Dr. Vikrant, for a successful case presentation. Thank you, Naseema and Shraddha, ma'am. We'll move on to the questions without wasting more time. So why anti-TPO is not done? Someone has asked.
What not done?
TPO antibodies.
Okay, TPO antibody. How is that going to affect the anesthesia management as such? The TPO antibodies will only tell us that it's an autoimmune disorder. So maybe this investigation, okay, to rule out or to find out the etiology of the thyroid swelling is fine. But me asking for anti-TPO is not going to do any new change to my anesthesia management, I think. So once I have those T3, T4 levels, I have the extent of the gland. I know my difficulties in airway and in dealing with the thyroid levels. So I don't think it's going to add anything new to my management. So I don't want to tax the patient from my end. If the surgeon wants to know, fine. But as an anesthesiologist, I don't think it will add anything new to my existing management plan. Once I know the T3, T4 levels, once I know the extent of the thyroid and the other difficulties that I'm going to face.
Thank you, ma'am. So basically, etiology is more important to the surgeons or the physicians rather than to the anesthesiologist. That's why I think it is not relevant in managing anesthesia. So what is the normal sleeping pulse rate for thyroid case? Dr. Kanchan has asked, more than 85 or 90 per minute.
If there is hyperthyroidism, if you want to rule out hyperthyroidism, it should be more than 90, the sleeping pulse rate. If it's less than 90, around 80, then it is normal. Because what happens, why you want it, earlier it used to be done, is when the patient comes for pre-anesthetic checkup, many of the patients are very anxious and scared. So maybe because of that, because of the anxiety, the pulse rate is higher when you are going for pre-anesthetic checkup. But that same pulse rate can come down to the normal, his or her normal baseline when he is in deep sleep. That's why the sleeping pulse rate was given importance to rule out for diagnosis of hyperthyroidism.
Thank you, ma'am. So do we check Pemberton's sign in examination? This we have already discussed.
We discussed.
Dr. Iqbal has asked why drug history is important.
Pardon? What? Why?
Drug history is important.
Many a times patients are on interferon and other drugs which can cause hypothyroidism, right? So drug history is also important, whether this is drug-induced hypothyroidism or drug-induced. Many times there is a slight thyroid swelling seen in ladies. So for cosmetic purpose, people already, some of them, they start even thyroxine for cosmetic purpose to reduce the thyroid swelling. And that may lead to hyperthyroidism many times. I have seen patients, like patient taking minimal thyroxine for thyroid because the thyroid swelling is seen, and for cosmetic purpose people are taking thyroxine, and this leads to hyperthyroidism many times in this patient. Landed up, one of my relative landed up with hypertension, tachycardia, severe tachycardia. Then patient had to be started on antihypertensive and beta blockers. So drug therapy medications is really important to rule out whether it is drug induced, or it is also called as, I think, hyperthyroid factitia, something like that. Rule out drug induced hypo or hyperthyroidism.
So ma'am, next question is TSH level to accept or defer elective case.
I think the baseline up to 4.5, even we are doing cases up to 5.5 and 6. If we are going for regional and GA also, we see many times patients are coming out very nicely, even with 6 TSH, right? Secondly, one more thing I forgot about the drugs is many times the patients are anxious, patients are having palpitations, they are on beta blockers. So these beta blockers can mask your tachycardia, which could be due to hyperthyroidism also. So drug history is very important in all the patients.
Thank you, ma'am. So the next question, I think we've already discussed, what if there is no fiber optic bronchoscope available? Then what approach to follow in an anticipated compression syndrome?
Shraddha has already explained.
This has already been taken.
Inhalation,
So,
yes.
yeah. So the next question is by Dr. Leena. Is there any role of sleeping pulse rate in current era?
Nowadays, I think most of the patients who are coming with pure thyroid only. I have nowadays, maybe in medicine OPD or endocrine OPD, they may be having hyperthyroid patients. But when patients are nowadays coming to us, they are coming with euthyroid and all their TSH and thyroid function tests are normal. But I think if many times, sometimes I ask my students to go and see the sleeping pulse rate. Just to rule
now
out.
that we have investigation, we might not rely on that as such, but that's something we should know. Not that we are
sometimes
going to
what happens in
it.
PSC, the heart rate is on higher side, maybe because of anxiety only and stress of patient has stress of surgery and PSC. So sometimes, rarely, but usually we have all the, as Shraddha said, we have the investigations at hand. The recent investigations are always there to confirm the.
Yeah. So, but we should not forget our roots, like where we began from. So it is important to know this.
Yeah.
So
the students should know. The
yeah.
students should know the importance of the sleeping pulse rate.
Yes, ma'am. What to use for rate control in asthma patient with hyperthyroidism? Dr. Rahul has asked.
Asthma patient with hyperthyroidism. Propranolol is routinely used and it's safe.
Maybe Ismolol is a better
Cardio blockers,
That is
short acting is a better option.
Yeah, but if it is intraoperatively, if Shraddha, I think if it's an emergency and we have to take the patient, it's okay. Ismolol we can use. But routine elective cases, the endocrinologists or the physicians, they usually use propranolol or metoprolol also sometimes.
Maybe
So-
metoprolol can be used instead of propranolol.
Dr. Leena has asked any suggestion about awake preoperative fiber optic bronchoscope for airway assessment if available as a routine checkup in tracheal compression. Maybe she's asking that can we use fiber optic bronchoscope in preoperative area as a diagnostic modality, maybe.
If you are doing an ideal, I think.
Yeah, ideal for the cords, and plus we have 3D CT scans now.
Yeah.
So we did not invade. We did not invade into the airway as it is.
And if you want to go for fiber optic, you might as well do it on table at the time of surgery only. You can induce as well as.
Patient is anyways awake.
Yeah. And nowadays patients are usually coming to us with CT scans and MRI. So we have the idea, a general idea about the compressions and deviations of the trachea and obstruction if it's there. I don't think fiber optic should be used to assess the
Each and every patient maybe.
for airway assessment preoperatively, because it also requires airway blocks. It requires some sedation for fiber optic also. You can't just put a fiber optic directly in an awake patient without any sedation, without any airway blocks. So if you're going to do
Cannot be done in a
procedure,
OPD
might
setup.
as well do it on the table itself at the time of induction.
So our next question is,
It is definitely.
sorry.
Yeah, it is definitely not an OPD procedure.
Yeah. So our next question is, if we lift, Dr. Vamsi has asked, if we lift the thyroid storm chance will increase or not?
We are not manipulating it that much. We are just slightly lifting the thyroid. If you feel that the tube is not going further, then you can ask your assistant to lift the thyroid, but it's very gentle. You are not manipulating or anything. Manipulation occurs during intraoperatively with the surgeon.
There could be a slight increased chance, but then your airway takes the priority at this time. If you can't intubate, you have to do it. If you already induced the patient.
Correct.
So Dr.
But you're
Nitin
not
has
handling
asked,
it as such.
yeah. Dr. Nitin has asked about the airway blocks and huge thyroid swelling for awake fiber optic intubation, how to perform it.
It's difficult. Airway blocks with a huge thyroid, you can't, I don't think you can give intratracheal, or you can go in the cricothyroid membrane also. With a huge thyroid, it's difficult. And
So what
I
we
think
can
he
do
wants to
here
know how to
is,
manage awake
so what we
fiber
can
optic.
do, we have viscous gargles. So 10% viscous gargles are available. So that we can ask the patient to gargle for the oropharyngeal area and spit it out so that you don't overdose. Then you can use jelly for the nares. And what we can do, because we cannot give intratracheal, is you can put a syringe on the fiber optic itself and spray as you go in. Of course, you'll have to counsel the patient. You'll have to reassure the patient, talk to him about the procedure beforehand so that he stays comfortable. You tell him that a little discomfort is possible so that he's prepared for it. We can spray as we go in. That's the only thing we can possibly do, since we can't give airway block.
Yeah.
That is one option which is possible.
We can do nasal packing in the preoperative phase. And as she has said, gargle also for the oral mucosal anesthesia. And intranasal packs you can keep preoperatively. And as she said, as you go through inside, you keep spraying. There is this thing for it also. Syringe, you can spray it. But it's not possible. Airway block is not possible when there is a huge goiter.
So Dr. Jitesh has asked, what are the differential diagnosis of thyroid storm? Like how you can differentiate it from the other things happening intraoperatively?
Malignant hyperthermia, neuroleptic malignant syndrome, and pheochromocytoma. Each and every. Now, if it's a malignant hyperthermia, I think the patient will be posted for surgery 2-3 times, where you have used scoline. So you know that this patient has been exposed to anesthesia earlier. Now, we don't use halothane. One of the drugs which are responsible is choline and halothane for malignant hyperthermia. So halothane is not used nowadays. Rarely it's been used. And choline, also nowadays we take directly patient on non-depolarizing muscle relaxants. So you can rule out malignant hyperthermia, yes, on the history from the incidences. Yes, sure.
Mainly mainly a diagnosis of suspicion.
Yeah.
So if it is happening or correlating with your thyroid handling, or if it is happening, let's say 2-3 days after your patient has undergone a thyroid surgery, or we knew that his hormone levels were a little haywire already, we expect more of thyroid crisis than anything else.
Now, in thyroid patient, we first thing it suspect is thyroid storm. A patient not having any thyroid swelling, yes, you can say, and already exposed to anesthesia 2-3 times, that is more towards a malignant hyperthermia, right? And the thyroid storm intraoperatively, I have not seen a single thyroid storm case up till now in my 30 years and my so many years of practice. Yes, thyroid storm, they have said it's mostly common after 8 to 16 hours after post-operatively, it might be seen. But intraop, up till now, I have never seen thyroid storm.
So Dr. Rahul is asking, what is the earliest sign of thyroid storm intraoperatively? Tachycardia or hypercapnia or earliest
hypercapnia? Hypercapnia. Sudden shooting hypercapnia twice. 3 times, 4 times. Sudden increase in ETCO2 of 3 to 4 times. Probably point towards thyroid crisis. Because tachycardia has multiple reasons by the time you rule out one level. But sudden hypercapnia, shooting more than double or triple, is probably the warning sign, the earliest warning sign that you're probably landing up in a thyroid crisis, along with hyperpyrexia also. So hypermetabolic state. These two together are more pointing towards the hypermetabolic state than anything else.
So hypercapnia will be there along with, I think, tachycardia will be there, sweating will be there. This will be almost first maybe increase in the ETCO2. Then tachycardia will be there simultaneously. Body temperature might be increased. Hypothermia may be there, profuse sweating. So these are the earlier indications of thyroid storm.
To stop the peripheral conversion of T4 to T3, what all anesthetic drugs can be used other than thiopentone sodium?
I think dexamethasone can be used to stop the peripheral conversion of T4 to T3. Even epcholin to some extent can prevent the conversion of T4 to T3.
Then, ma'am, the next question we've already discussed, TSH of 10 is acceptable or not?
TSH of
10.
TSH of 10 is acceptable
10.
or not?
It depends.
10 we have not used.
So see what the T3, T4 are like. See whether the patient is clinically euthyroid or no. So if it is a subclinical hypothyroidism, maybe yes, we can accept. With no if the patient is having no symptoms. So it depends on the clinical symptoms and as well as the T3, T4 levels also. And the emergent nature of the surgery. So the surgery is actually not emergent, why not optimize?
Yeah. Only for emergency. I think up till now, up to TSH of 6 or 7, we have given anesthesia. But when it comes to 10, we have asked, if it's not an emergency surgery, we have asked them to optimize the patient, start Eltroxin or something, wait for a few days and then take the patient for surgery.
Sure. Emergency LSCS with TSH of 13, what would be the plan of management?
I think regional anesthesia would be the best choice. And with low volume of local anesthetic, maybe 1.5.
Avoid any sedation
or something.
Why Vikrant has gone into hiding with these questions being asked?
Sir, he's exhausted, I think. He's tired. He's studying.
विक्रांत हमको वाइवा देने बिठा के चला गया.
The
Last
reason
one
is,
whole week.
this is the time actually when you are giving a long case viva for 1 hour, you are being questioned by the examiners non-stop. Here you are going to tend to make mistakes while answering. So try to make the stamina for answering those things. I think this class prepares you for answering very well. And I think a majority of the questions are being covered now.
Has been covered.
Small
Yes, sir.
questions are coming up, which are I think usually you always do on the table teaching to all the students. Dr. Madhuri want to say something before I conclude the thing. Dr. Madhuri, you unmute yourself.
Welcome, madam.
Yeah, congratulations, Nasima ma'am, Shraddha,
Thank you,
and Dr.
madam.
Vikrant for a very,
Thank you,
very
madam.
Thank you,
beautiful,
ma'am.
very nice, elaborative, and very detailed, very good presentation.
Madam, I hope we have
Thank you,
stood
ma'am.
up to your expectations.
Not at all. I have to stand up to your expectations.
No, madam.
Right.
Thank you very much. for
Thank you,
this
ma'am.
session.
Okay, thank you.
Thank you,
I
ma'am.
just
Yeah,
had one
honored.
Means a
question.
lot.
I had one or two questions for Dr. Vikrant.
No, don't ask a long question, Dr. Madhuri.
No,
Time is
small, very brief question because I know time is short. This is for Dr. Vikrant.
Vikrant, are you there?
Yes, ma'am.
semi-final. This is semi-final question.
Vikrant, is there
Final,
any
final.
Vikrant, is there any role of video laryngoscopy for intubation, extubation in the case of huge thyroid?
Ma'am, it would be useful to use video laryngoscopy. Fiber optic intubation has upper hand than video laryngoscopy, but we can use video laryngoscopy, ma'am.
Definitely you
And-
can use. Especially if you're doing, as you told in, madam asked you one question, no? If the fiber optic is not available and you're
Yes,
doing inhalational induction, then you can use a video laryngoscopy.
Video laryngoscopy, ma'am.
And one more, even you can use it during extubation to when you want to visualize the
Use the
vocal.
cords, ma'am. If I want
Okay.
to see the show the surgeon the cords.
Right. And during extubation, you said you use a tube exchanger, right? Tube
Yes, ma'am.
an exchange catheter. That's right. Can you exchange the tube, tracheal tube, over a supraglottic airway device?
Yes, ma'am. I can. That
Please
is a
say that.
Bailey's manure for extubations, ma'am. We can use we can introduce a supraglottic airway and extubate.
one?
ma'am.
How
Which
will
one?
that help? How will that help? Tell.
Ma'am, there will be like during extubation, laryngeal spasm can occur. We can avoid that laryngeal spasm if we are confident enough that tracheomalacia is not there.
Not only that, they say that it will reduce the incidence of coughing, bucking, and all.
Yes,
So
ma'am.
that will be beneficial in thyroid surgery.
Yes,
Then
ma'am.
one more thing which I would like to add is the type of endotracheal tube that you're going to use for the thyroid case.
Ma'am,
will
I would
be
go for fiber of
armored flexometallic tube or any other tube other than flexometallic. Any other tube you can use.
is your RA
RA tube. Yes. North Pole, South Pole. Okay.
North Pole.
North Pole
North
tube.
Pole or South Pole?
North Pole or South Pole?
Which pole?
North से south.
Let him answer. Huh? फंस गया
कुठला
यार.
पोल
North
कुठे
Pole, South
कहाँ
Pole.
गया?
Ma'am, neural and integrity monitoring tube also I can
Exactly.
use.
Exactly. I wanted that answer from you.
Okay, okay.
Neural integrity, ray tube though is there only, but the neural integrity monitor, electromyogram tracheal tube,
The vocal cord,
that
yeah.
can be used for what you tell me? To
To,
detect
ma'am,
damage
see-
to the
Of recurrent laryngeal nerve, damage of
Yeah,
any
so-
recurrent laryngeal.
yeah. So when the surgeon is near the recurrent laryngeal nerve, what happens? This device will give audible clicks.
Yes,
So
ma'am.
that will help you, but it has got its own reserves. Like there are chances of fire. You have to use low FiO2. Then when you intubate, you cannot use a depolarizing muscle relaxant.
Yes,
you have
ma'am.
to use you cannot use a non-depolarizing relaxant. So there are some reservations about that. But that's a new thing. Okay. And Vikrant, suppose I tell you that could you do this thyroidectomy under regional blockade? Which block you will use?
Ma'am, I would use deep cervical plexus block and superficial cervical plexus block. And if
Both
possible,
you will use and bilateral or what like?
Ma'am, I will not use bilateral. I will go for unilateral only because bilateral may cause recurrent laryngeal nerve palsy.
So
Or
unilateral means then action will come on both sides, or how, like?
ma'am, action will come on the
Which you will
same
go
side
for
only.
bilateral, which you will go for unilateral. Which block will be bilateral, which will be
Bilateral superficial, I will go, ma'am. Bilateral superficial laryngeal nerve. But for recurrent laryngeal nerve, I will
Laryngeal
Cervical
nerve?
plexus block, cervical plexus,
cervical,
no?
cervical.
bilateral superficial cervical plexus block, but deep cervical plexus block will be unilateral.
So if it's a huge mass, your unilateral block will suffice.
Ma'am, cervical epidural also then we have to use, ma'am. But it should be done
Ek
by...
minute. Have you ever used cervical epidural in your institution?
No,
Then
no,
don't
sir.
answer these things. I'm telling you. Make sure all the PG students who have not used the technique, they should not answer those techniques with a confidence. You say these are mentioned in the books, but for the safety of patient, we are not using it regularly, but we know about it a little bit. The examiner will be a little bit satisfied with that. You make a blunder here, na? Just the way you are, I think you're trying to make a blunder out of all the hard work done in the day. So just be careful here.
Good.
Yes, sir.
Okay. Okay. Good, Dr. Vikrant.
Thank you, Dr. Madhuri, for enlightening us with so many
Thank you,
questions.
madam.
And,
Thank you, Madhuri.
Thank you,
guy
ma'am.
is really getting fatigued now. But Vikrant, actually today, the way the Viva was conducted, it was the same way during examination. The
Yes, sir.
examiners ask the question in a very slow voice, in a slow tone. And sometimes if you don't hear the question, you have to ask the examiner, ma'am, sir, pardon, I haven't got the question. Because if you think that the examiner will get angry or something, you are at the loss. So today it was less like an examination room going on. The voice, the manners, typically in the examination section or the corridor of the wards or wherever the pre-op room when the patients are kept, the same voice, the same tone is is kept there. I think Dr. Naseema Kanse madam and Dr. Madhuri were both examiners together. So they
Yes,
are going
sir.
to rip you apart if you make any blunder. So if you are in doubt, ask the teacher again. Pardon, please, can you repeat the question? That's very important.
So one last question for Madhuri madam. Is she there still?
She can't run. She has to
I'm
answer.
there, tell me.
Madam, have you done any thyroid surgery under supraglottic device?
No, I have not yet done any. Have you done?
No, madam.
I have
Can we
not
do
yet
it?
done.
Can we do it?
See, these questions, the supraglottic devices and the thyroid surgery or neck surgery, they will keep coming up, they will keep propping up. But how much comfortable you really are with the supraglottic devices during thyroid surgery? Do you get enough time to secure the airway in case they get displaced, or you are putting the
So
patient at
basically,
risk?
the position is
Exactly.
extension.
Exactly.
So LMA can get dislodged in between also. Then it will be very difficult to ventilate the
You
patient.
share the surgical scenario with the surgeon, and I think let him do the surgery in a very good, relaxed manner.
He is also comfortable. We are also comfortable.
Yeah.
So,
Yes.
And one more point would be that in the thyroid case, the entire internal anatomy is distorted inside. So for the supraglottic airway device to sit also becomes a problem there, isn't it?
True. It's
But
always good to have the airway in your hand.
there are case reports where Procil LMA has been passed for thyroid surgery, but they're just case reports.
Yeah.
That is if you cannot, if
Yeah,
the
Not
tube
actually
doesn't
safe.
go, you have
I
to
think.
go for the surgery.
Yeah.
But it's always better to have a complete airway control always.
Yes, definitely.
Thank you, madam.
Anyone want to give any more further suggestion before we wind up with the class? Any person, anybody? You can raise hands or you can unmute yourself. I will just let me
Thyroid 6 syndrome. I think Vikrant, you know what is thyroid 6 syndrome?
Vikrant?
I mean, euthyroid 6 syndrome because of some severe illness, which leads
Some other
to
illness other than thyroid.
other than thyroid illness,
A non-thyroid
there is severe
illness.
illness which causes to decrease TSH, T3, T4. So all the thyroid hormones are decreased, but it is because of another illness. As soon as that illness gets treated, the euthyroid 6 syndrome, the patient will come again. There is no requirement of giving medications because in the euthyroid 6 syndrome for thyroid.
Good. Well
I
read, Vikrant.
I think Vikrant has done wonderfully well. Now
Yes, sir.
time is over almost. We have almost above 11 minutes from the
So
restricted
excuse me,
time. There will be many more questions keep coming up because it's such a large topic. But
Yes.
the main idea was to prepare all the PGs for facing the examiners, whether they speak in a low tone, whether they speak in a different tone, the tone of the examiner. PG should not be getting disturbed or perturbed by the tone or by the mannerism in which the examiner asks question. They should be well prepared for themselves in their own manner. They should not be losing their self. So that the calm and composure should be there. That's very important. If you don't know anything, again I am repeating, don't answer those things because any blunder you are putting yourself into a negative zone. So these are the small pearls how to face an examination also. We can come up very soon with on this PG classes also how to face the examiners and how
Yes.
to really do good in examinations, especially the postgraduate examination, not the undergraduate. So we will be coming up with that panel discussion very soon. It is going to be started within a week. From next week onward, we will be having some other day for the panel discussion.
Yes.
So it was really wonderful listening to the moderators as well as the student. Vikrant had done a wonderful job. I think he must have prepared some question already must have discussed with the professors, and half of the questions were not prepared. So this is the way the examination should go. So now I hand over to Dr. Monica.
Before we end, I take this opportunity to thank you for giving Karad
Ma'am,
IS
no, thank you, ma'am. This is
asked
our
for
common
the
platform. No, ma'am, no, thank you to
for
anybody.
giving us this
Ma'am,
platform, sir.
I openly want to say on this platform, no teacher, no presenter should say thanks to the secretary or something like that. It's an open platform. No, thank you to anybody. It's our common platform
Yes, sir.
for all the PG classes throughout India. There is no thank you.
Sir.
That culture should be abolished on this platform. Yeah, we should thank the teachers who have made their best efforts to prepare for a student for this class. And we also encouraging our students, especially the student who is presenting. That's a very, very bold way actually to how to go further about the questioning.
Thank
So
you, sir.
we
Thank
should
you,
thank the
sir.
teachers and the students, not the other way around. So that's I
Thank you,
think,
sir.
Monica, next time onwards, we will say in the beginning that no thank you, no obligation of anything. It is a part of our duty also as a senior person. So I hand over the stage to Monica to conclude the session. Monica.
Thank you, sir. So before concluding, I just want to request all the participants that if you are in your working areas like ICU or operation theaters, kindly switch off your videos because it is not nice that your patient is visible and you're managing the patient and the face of the patient is visible on this platform. So it is my humble request. And thank you all the teachers, and thank you, Dr. Vikrant. It was a nice presentation, and I think we have learned a lot in this session. And in fact, I have learned some. I have added on to my knowledge as well. So may this goes on, and we'll see you on next Monday in ISA online PG classes.
Next Monday we have got a class on ECG. So it will you have a spot diagnosis. No? Spot diagnosis comes for any patient. The examiner always asks ECG. That's a very tricky part. So we will be having a class on ECG. It will be interactive session. The teacher will be asking the students here in between. And next time onward, it's a good suggestion by Monica. So we will keep the instructions ready during the message. In the message also we will keep the instruction 5 or 6 instructions. Keep your mobiles almost switch off or on the silent mode and video to be on if you are in a proper attire. So that time we will be keeping these things. Thank you, Monica.
Sure.
So nice of you to convey these suggestions. And I think it's a better way to go now, so that Vikrant also should have a good food now. Vikrant, you must be feeling very hungry.
You'll have a good night's sleep, sir, today.
Yeah, he will be having a very, calming sleep. That exam is over. Half exam is over. I'm also thankful to my entire team here. Monica, Nishant is there. Dr. Madhuri, everybody is there almost. So Dr. Parul is here, but they don't switch on their videos when they are not comparing. So anyway, thank you everyone. So we should conclude.